So good morning. My name is Diem-Lan. I'm an infectious disease physician in Geneva, and I will present the update of the SSI guidelines on the management of acute diarrhea. So after the quick introduction, we will go through the clinical definitions and the main pathogens involved in acute diarrhea. We will then discuss the pertinence of molecular diagnostic and the antibiotic resistance, of course. All of these elements will help us understand the final algorithm that we propose in the updated guidelines for management of acute diarrhea. So, acute diarrhea, the incidence in Switzerland is more or less 2%. The disease is mostly mild and benign, and it requires only medical consultation only in 10% of cases. But the socio-economic impact can be important, with up to 86% of medical certificate delivered and a median sick leave duration of 4 days. Diagnostic tests and antibiotic prescriptions are needed in only less than 10% of cases. So here are the main clinical definitions for acute diarrhea. We will not go into detail, but these definitions are helpful to guide the differential diagnostic and to help to assess the need for empirical treatment, for testing, and for antibiotic prescription. So viruses are the first cause and the main cause of acute diarrhea. Rotavirus, norovirus, sapo, astro, and adenovirus can cause acute diarrhea. Usually the disease is self-limiting, except in immunocompromised patients where the disease can be prolonged and cause chronic infections. Usually viral gastroenteritis are associated with general symptoms and with nausea and vomiting. Rotavirus is the first cause of severe diarrhea in infants, but the vaccine has allowed to sharply decrease the hospitalization and mortality rate worldwide. So now, Rotarix is recommended in the Swiss vaccination plan since 2024. Norovirus is the first cause of acute diarrhea during epidemics. Why? Because it has a low infectious dose, it has a high resistance to environment, it has a high genetic variability with poor cross-protection among genotypes. There are asymptomatic carriers who can nevertheless shed a high amount of virus, and infectivity can precede symptoms and persist after symptom relief. But the morbid mortality remains low, with less than 1% of hospitalization and less than 0.1% of mortality, which affects mainly the extreme of age. What about bacteria? Campylobacter is by far the most prevalent bacteria identified in acute diarrhea. It is followed by Salmonella and enterohemorrhagic E. coli, and to a lesser extent by Shigella and Listeria. So Campylobacter, the first cause of bacterial acute diarrhea, causes a self-limiting disease, although it can induce an inflammatory and bulky diarrhea. The complications are the Guillain-Barré syndrome, can be a Guillain-Barré syndrome, and antibiotics can shorten symptom duration, but only by 1 to 2 days. Salmonella is the second cause of bacterial acute diarrhea in Switzerland. It also causes self-limiting disease, but in some circumstances, it can cause invasive disease. And the issue is the secondary infections, such as osteomyelitis, arthritis, prosthetic material infection, mycotic aneurysm, meningitis. This occurs in 5 to 10% of cases, but mainly affects at-risk population, such as patients with HIV, immunocompromised patients, patients with malaria, malnutrition, and in the extreme of age. Some Salmonella species also are more virulent, but they are not really prevalent in Switzerland. Antibiotics, except in the case of invasive disease, are not really helpful, and they can even prolong the shedding of the bacteria. Among the pathogenic E. coli, the enterohemorrhagic E. coli is the most frequent one identified during acute diarrhea. It carries a Shiga-like toxin that can induce hemolytic uremic syndrome. And in this case, antibiotics mustn't be prescribed because they can increase the secretion of this toxin. And finally, acute diarrhea caused by Listeria are also self-limiting, and only in case of invasive disease there is an issue because it can cause sepsis, meningoencephalitis, and miscarriage. Again, population at risk for this complication and invasive disease are those in the extreme of age, pregnant women, and immunocompromised patients. So what about traveler's diarrhea? During traveling, the main cause of acute diarrhea are bacterial, up to 80 to 90%, and only in 5 to 10% of cases there is a virus or a parasite identified. And among bacteria, enterotoxigenic E. coli is the first cause of traveler's diarrhea. It also causes self-limiting disease, but antibiotics can decrease the duration of symptoms. Typhoid fever is caused by Salmonella typhi and paratyphi, and is an important cause of acute diarrhea or of sepsis during travel because the mortality can reach up to 10 to 30%. And this mortality rate can be decreased by antibiotic to less than 1%. So in this situation, antibiotics must be prescribed. So now we will discuss the relevance of molecular diagnostic tests. As we have just seen, acute diarrhea can be caused by several pathogens, and the clinical presentation and evaluation cannot reliably distinguish between these pathogens. So multiplex PCR panels can catch several targets and is very useful for this syndrome. As you know, molecular diagnostic tests are more sensitive than standard culture-based diagnostic. In this study, the positivity rate of culture was about 8% and increased to up to 20 to 28% using molecular tests. But the results should be considered in light of the pathogenicity and the epidemiology of the pathogen identified. For example, some E. coli, the pathogenicity of some E. coli has not been well studied or understood, and the identification of a Vibrio or Entamoeba in a patient who has never traveled abroad should be challenged. There is up to 24% of detection among asymptomatic controls, and there is 15 to 30% of detection of multiple pathogens. So this is a challenge for interpretation of results. So multiplex PCR panels are fast, easy to perform, are very sensitive, can reduce additional tests and antibiotic use, and reassure the patient and the doctor. But the interpretation should be prudent, especially in case of co-infection or asymptomatic carrier. False positive results can lead to overtreatment, and they can only detect genetic sequences, so they don't provide any information on the infectivity of the pathogen. As all pathogens are screened, you have to deal with the results, even the false positive ones. And the high specificity can theoretically miss variants. So now, 2 words on resistance. So this data come from ANRESIS. So you can see that Salmonella, Shigella, and Campylobacter strains diagnosed in Switzerland already demonstrate some level of resistance to quinolones. And that's the reason why this is not the first-line treatment for empiric treatment of acute diarrhea. Antibiotics for acute diarrhea are clearly have a clear benefit in case of typhoid fever, as we have seen. They are life-saving in this condition. They can reduce symptom duration of about 1 to 2 days in case of severe disease with Campylobacter. But they can prolong Salmonella non-typhi excretion. They can induce C. diff infection and dysbiosis. They can induce hemolytic uremic syndrome. They promote colonization with multi-drug resistant bacteria. And one study identified also a prolonged hospitalization duration. So now, in light of all this data, we will try to understand this algorithm that is proposed in the updated guidelines. So basically, there are 4 situations and attitudes towards acute diarrhea. The first one is wait and see. The second is treat and see. The third is treat and test. And the fourth one is test and see and treat. So the first situation is the most frequently seen. Most of acute diarrhea are self-limiting within few days, whether the cause is viral or bacterial. So in a patient with a recent onset of symptoms, with mild to moderate symptoms, with a good general condition, you can provide symptomatic support and recommend a follow-up only if needed. The second situation is the traveler's diarrhea. In this situation, as we have seen, there is a high probability of bacterial infection. So antibiotics prescription can be justified. Diagnostic tests will probably not change the treatment in most cases, will increase costs, and may be complicated to obtain during the weekend, for example. In this situation, we will clearly favor the patient's comfort, but there will be no consideration of antibiotic stewardship. Nevertheless, in case of persistent diarrhea over 14 days, or if the clinical presentation is severe, or in case of lack of response to empirical treatment, in this situation, microbiological diagnosis is recommended, including testing for parasites that can occur in 5 to 10% of cases. The third situation would be the case of a patient with severe symptoms, such as presence of dysentery or sepsis, and these signs are signs of invasive disease. So you have to start antibiotics quickly and not expect the results of the microbiological diagnosis. But in parallel, you have to test, and once you have the results of the pathogen, you have to adapt the treatment accordingly and according to the antibiogram. And finally, the fourth situation would be a situation where the clinical presentation is not as severe as the previous one, but there are some worrying elements like persisting fever, prolonged diarrhea over 5 to 7 days, and or older patient with some frailty. So in this situation, you can test, and according to the result, you can treat if the symptoms have not resolved in the meanwhile. And we have seen previously the population at risk for invasive disease and complication. So if your patient belongs to one of this category, you might test and or treat earlier or more easily than what is recommended in the guidelines, because there are some risk for severe infection. And you have also to know the prevention measures to avoid infection and to discuss them and transmit them to the patients. And finally, a quick reminder of the notifiable disease to FOPH. So with that, I would like to thank Veronika Beitig and Adrienne Rohrbasser who work with me on these updated guidelines, as well as Esther Kunzli, Stefan Meidel, and the GP and nurses who provided their inputs. Thank you for your attention.